All right, Marilyn. There's this number, right, that honestly, it really matters more than anything else in the whole public health story this week. And it feels like almost no one's actually saying it out loud. The MMR herd immunity threshold, it's 93%. And get this, national MMR uptake for the 2024-25 school year was like 92.5%. We're, half a percentage point under the line. We've been under that line for an entire school year now. And those 1,792 confirmed measles cases that CDC reported as of April 23rd, 78% of last year's total in just, 4 months? That to me is not a surprise at all. It's just the arithmetic catching up, isn't it?
Oh, Marcus, it's worse than that, honestly. It really is. I mean, of those 1,792 cases, 92% are, get this, in unvaccinated or unknown status individuals. The disease is it's doing exactly what it does when you drop below that threshold. It finds the seams, There's really no policy mystery here. The mechanism is it's functioning as designed. It's almost brutally efficient in a way at finding those vulnerabilities.
Right. And here's what I really, really want everyone to kind of walk away with after the next 15 minutes or so. Most of the analysis you've read about this story will tell you that Americans are rationally rerouting their trust around a broken federal system, that local pediatricians and prediction markets and professional associations, they're all kind of picking up the slack. That's like the reassuring narrative, right? But by the end of this episode, you'll know exactly what that substitution can do, and more importantly, exactly what it absolutely cannot do. You'll know which side of that line decides whether we actually lose measles elimination status this November. A status, by the way, this country has held since the year 2000. That's a big deal.
And you'll know why a story being told as resilience, like, oh, we're being resilient, might actually be the cleanest indicator we have that something irreversible, something fundamental is already happening. It's a bit of a chilling thought,
Yeah, it really is. We're going to start with what the data actually says, not what the narrative says it says. We got to get into the numbers.
The arithmetic it doesn't care about the narrative, Marcus. It really doesn't.
It really doesn't. That's the truth of it.
So let's just lay out the institutional account here clean, right? In June 2025, HHS Secretary Robert F. Kennedy Jr. dismissed all 17 members of the Advisory Committee on Immunization Practices, ACIP for short. That's the committee that, by codified procedure under the Federal Advisory Committee Act, actually recommends vaccine schedules. Then, in January 2026, Acting CDC Director Jim O'Neill issued a unilateral schedule reduction. 17 recommended childhood vaccinations down to 11. Routine guidance removed for rotavirus, influenza, and hepatitis A. This action, it followed a presidential directive to align the U.S. schedule with other high-income nations. Now, on March 16th, U.S. District Judge Brian Murphy ruled that schedule change unlawful. His exact language? He said HHS had disregarded the codified scientific process. The action was arbitrary and capricious, and the agency lacked authority. HHS is appealing that, by the way.
Yeah, and I want to interrogate the framing here rather than the facts themselves because, the facts are the facts, right? The dominant analysis, and you can find this in pretty much every long-form piece written about this since March, it takes one assumption as load-bearing. The assumption is that there's a meaningful distinction in the story between the institution and the people running it. That the institution exists as a structure, the leadership exists as these variable occupants, and the structure just kind of persists through whoever happens to be sitting in the chair at the time.
That's like the standard administrative law framing, isn't it?
It absolutely is. And here's what I think it gets wrong, really wrong. Murphy's ruling is being read as the institution just reasserting itself against bad faith leadership. That's not what happened. Murphy is one judge. The Administrative Procedure Act is a statute, on paper. Neither of those is HHS. HHS is the actual operational machine, and the actual operational machine is doing exactly what its leadership directed it to do. The 17 ACIP members, they're gone. The schedule recommendation, it got issued. The agency's communications align with leadership, not with Murphy. The institution and the leadership they aren't separable in the way the standard framing assumes. Not in this context.
Okay, give me the analogy then. Help me, wrap my head around this separation you're talking about, or lack thereof.
Okay, so think about how a country's effective tax rate diverges from its statutory tax rate, right? The United States, it's had a 21% statutory corporate rate since 2017. But the effective rate, what's actually paid by S&P 500 companies, has consistently been below 15%. When that gap widens, you can keep saying you have a 21% tax regime, but you don't, really. You have whatever rate is actually being collected. The statutory number is, it's the press release. The effective number, that's the system. What we're watching with HHS, it's the effective rate of public health governance dropping. Murphy, he raised the statutory rate back up on paper, but the effective rate it keeps dropping. That's the real story, I think.
Wow, okay. I want to push back a little bit here because I think you're framing it's doing analytical work that the data doesn't fully support, right? The Annenberg survey, it says 86% of Americans still report confidence in primary care providers. AAP, the American Academy of Pediatrics, at 77%. AMA, 73%. Career scientists at federal health agencies, 67%. So the professional infrastructure underneath HHS leadership, it's actually intact. And the substitution behavior we're going to talk about in a few minutes, that's exactly what's keeping uptake at 92.5% and not at 78%. We'd be in a much worse spot, wouldn't we?
That's the exact question I want to put on the table for the rest of the episode, Marcus. You called it substitution. Is it actually substitution, or is it a coping mechanism that looks like substitution from the household level, but is something else entirely, at the system level? That's the core of it.
Let's go work it. Let's dig into that because I think that's super important.
So the second order effect almost nobody is tracking, and this is crucial, is what happens to the layer underneath that substitution. The Annenberg survey told us where confidence is going. It did not tell us what those confidence-receiving institutions are actually equipped to do. The American Academy of Pediatrics, AAP, it's a professional association. It has 67,000 members, which is great, but it has no statutory authority. It has no budget for outbreak surveillance. It has no manufacturing relationships with vaccine producers. It has no jurisdiction over schools, daycare, or border health screening. What it can do, and does extremely well, is publish guidance and influence the practice patterns of pediatricians who are dues-paying members. That's its lane,
So when the survey shows 42% of people would follow AAP guidance over CDC guidance on newborn hepatitis B, and only 11% would follow CDC, that's a 4-to-1 preference for an organization that is structurally built for one specific function, and not, the other 10 functions HHS performs. That's a huge disparity.
Right. And here's the lateral connection I want to draw, because I don't think this is a public health story at the second order. I actually think it's a monetary story. Really, I do.
Whoa, walk me through that. That's a big leap.
Okay, so when citizens in a country with a weakening currency start pricing things in dollars, rent, salaries, big purchases, the standard reading is that they're protecting themselves rationally against inflation. That's true at the household level. But at the system level, every transaction priced in dollars is a transaction that no longer creates demand for the local currency. Velocity of the local currency drops, the central bank loses transmission, it can adjust rates, and nothing happens because the rates apply to a currency people aren't using anymore. The household behavior is rational, the aggregate is currency death. Argentina has run this experiment 3 times. Lebanon is running it now. The hard part of the dollarization story is that there is no precise moment when the currency dies. It just keeps existing on paper while not functioning. It's still there, but it's not actually doing anything.
And you're saying that's what we're watching with Federal Public Health Authority. That's a powerful, almost unsettling analogy.
I'm saying the trust substitution story is being told as if it's protective. Households are protecting themselves by routing to local providers, professional associations, prediction markets. Each individual rerouting decision is rational, but the aggregate creates a federal public health apparatus that, like a dollarized peso, just keeps existing on paper while losing the capacity to do what it was designed to do. The outbreak data, that's the symptom. The trust data, that's the cause. And the cause is not reversible by just replacing the leadership, because the trust substitution behavior, it's sticky. You can't just flick a switch and bring it back.
Let me do the projection now. And let me do it really grounded, 5 to 10 years out. If MMR uptake stays at 92.5% or drops further, The things you can mechanistically predict, they're not speculative at all. Measles elimination status is reviewed in November of this year. If the case trajectory continues at March's 5 to 6% weekly growth, not the recent 0.4% slowdown, which CDC's own update notes is too short a window to call, we lose elimination status. That triggers WHO reclassification. That triggers travel advisory cascades from countries that still have elimination. That triggers reciprocity questions for U.S. vaccination certificates abroad. None of that is hypothetical, really. The mechanism is the WHO's own protocol. It's just how it works.
And the U.S. domestic response, if I'm reading this substitution dynamic correctly, won't be a federal correction at all. It will be state-level patchwork, you know? Some states will tighten school requirements, some will loosen. Insurance reimbursement schedules will start citing AAP rather than CDC. The de facto national vaccine schedule, 5 years out, becomes whichever schedule the major insurers and major pediatric networks decide to align on. That is not a criticism of AAP, by the way. AAP is a serious organization, absolutely. It is just an observation that we are watching the slow privatization of a public function, with no decision moment, no debate, no vote. It just happens.
And no one in charge of stopping it, because the people who would be in charge of stopping it are the ones whose authority is being routed around. That's the loop, isn't it?
That's the loop, totally. Now, here's the claim I want to put under pressure, because I think it's load-bearing for the entire reassurance narrative being written about this story. The claim is, localized trust is a sufficient substitute for federal coordination on infectious disease. The capstone audit doesn't say that explicitly, but the framing, trust is being relocated rather than trust is being lost, it totally implies it. The Annenberg survey is being read that way, the prediction market analyses are being read that way. I want to test whether the claim actually survives, real scrutiny.
Okay, I'm going to construct the strongest version of the claim, right? Because I think it's stronger than the version Marilyn just summarized. Here it is. ACIP, by codified procedure, was the legitimate process for setting the federal vaccine schedule. ACIP has been gutted. The federal layer that would normally enforce vaccine policy has effectively been removed, not by accident, by design. In the absence of that layer, two things have happened. State-level requirements have continued to operate because schools require vaccines, and that authority is not federal. Professional medical associations and insurance reimbursement schedules have continued to operate on the pre-June 2025 ACIP schedule because their internal medical reasoning didn't change when the federal policies changed. So the de facto national vaccine policy is currently being maintained by a coalition of state health departments, professional associations, and insurance carriers, all operating on the schedule HHS abandoned. That is not the privatization of public health. That is the rule of law continuing through alternative authoritative channels when one channel is corrupted. Murphy's ruling is part of this. The substitution is keeping the system functional. Without it, uptake would be in freefall. With it, we are 0.5 points under herd immunity rather than 5 points. That's the strong argument, I think.
That is the strongest version, absolutely. Let me apply pressure to it then. Your version requires that the alternative channels can do the full set of functions the federal channel was doing. They can't, and you named the reason yourself. The alternative channels can maintain the schedule, yes, but they cannot conduct outbreak surveillance at national scale. They cannot negotiate manufacturing contracts. They cannot allocate vaccine supply during a shortage. They cannot coordinate cross-state response when an outbreak crosses borders. The 1,792 measles cases this year, those are not appearing inside one state. They are spreading across states whose public health departments have varying capacity. CDC's outbreak coordination function is the thing the alternative channels structurally cannot replace. Pediatricians cannot coordinate that, insurers cannot, AAP cannot. The substitution is keeping the steady state schedule functional, but it is not maintaining the response capacity. That's the real issue.
That's a fair pressure point. Let me hold the steel man against it one more time, though. Outbreak coordination at CDC has been functioning during this entire period. The 1,792 number is published by CDC. The weekly updates are published by CDC. The case classifications, 92% unvaccinated or unknown status, are published by CDC. The career scientists and the surveillance infrastructure are still there, They haven't just vanished.
For now, Marcus, for now. The Annenberg survey shows trust in CDC career scientists at 67%, which is holding, yes. But the survey also shows confidence in HHS leadership at 38%. The career scientists, they report up to leadership, right? If the leadership pattern persists, and the appeal of Murphy's ruling is like the big test here, the staffing pressure on CDC career scientists will continue. The CDC outbreak coordination function depends on people. Those people are subject to the same substitution dynamic at the labor market level that we're seeing at the trust level. They can leave. Some have. The infrastructure is not the building. The infrastructure is the staff, really. That's the core of it.
Yeah, I think the steel man doesn't survive that. I'll concede the point, Marilyn. The substitution is doing real work at the schedule layer, that's clear. But the response capacity layer is not substitutable. And the response capacity layer is what determines whether we actually hold elimination status in November. If we lose response capacity, the schedule layer, it doesn't save us, because measles will outrun the schedule. It moves too fast.
And that's what makes the poly market and Kalshi pricing so significant. Kalshi is pricing full-year cases over 2,500 at 0.68. The institutional narrative is at 0.55. That 0.13 gap, that's the market saying it does not believe the response capacity is intact. The market is not pricing the schedule, you know? The market is pricing the response. That's what it's telling us.
The substitution is real, but it's partial. And the part that's substitutable is the part being substituted. The part that isn't is the part that determines the outcome. That's a pretty sobering thought.
So here's the deliverable, right? I told you at the start of the episode that you'd know exactly what the trust substitution can do and exactly what it cannot do. Here it is, plain and simple. It can keep your child on a vaccine schedule. It can give you a clinician you trust. It can give you reimbursement coverage for medically reasonable care. It can, via the prediction markets, give you a more accurate read on near-term outbreak trajectory than the official narrative will give you. But here's the kicker. What it cannot do is conduct national outbreak surveillance, allocate vaccine supply during a shortage, negotiate with manufacturers, or coordinate cross-state response. Those are functions only the federal layer performs, and those functions are degrading because the staffing infrastructure that performs them is subject to the same trust substitution dynamic at the labor market level. So the action item is this: map the layer below you. Know exactly what your local trust nodes can and cannot do. The pediatrician can keep your kid current. The pediatrician cannot keep your county current when measles arrives via interstate travel. Your substitution buys time at the household level. It does not buy time at the system level, so plan accordingly.
And here's what's gonna keep me thinking, Marcus, after we stop recording. The trust substitution behavior is not reversible by just replacing the leadership. That's the part nobody is really saying. If Kennedy is replaced tomorrow, the AAP versus CDC ratio does not snap back to where it was in 2019. Trust is sticky on the way down in a way it was never sticky on the way up, you know? The institutions that absorbed the volatility, AAP, AMA, the insurers, the state health departments, they've built a constituency around the substitution. They are not going to hand that back. The longer the substitution operates, the more the federal layer's actual function decays, because the people who knew how to perform it are leaving the building. That's a serious brain drain.
And eventually, this is the part is like a really dystopian thought. Eventually, the people running the federal public health system will be people who grew up routing around it. They will not bring it back. They will administer it the way you administer a museum. You know, like it's there, it's a relic, but it doesn't do anything anymore.
And by then, we will have forgotten there was a function we needed it to perform. We'll just have lost that institutional memory. It's really sad, actually.
November is the test. 6 months. The arithmetic is doing its thing right now.
It always was.
Thank you for tuning in to this crucial discussion. If you found our conversation insightful, please remember to hit the like button, leave us a comment with your thoughts, share this episode with someone who needs to hear it, and of course, subscribe to our channel for more deep dives into these critical issues.
Absolutely. And as we've just discussed, Marcus, the implications of this partial substitution are really profound. It's not just about what individual households do. It's about the systemic failure of essential functions that no amount of localized trust can truly replicate.
Right. The numbers are clear, and your analogy of currency dollarization really highlights how insidious this decay can be. It's not a sudden collapse, but a gradual erosion of function, even while the structures appear to remain.
Precisely. And that erosion of the federal response capacity, That's the part that is entirely decoupled from the ongoing efforts at the local level. It's the invisible loss, but it's the one that will determine our actual health outcomes.
So, with that in mind, knowing the limitations of what we're calling substitution, how do individuals and communities truly navigate this landscape going forward?